So prolapse is essentially it's a hernia of the pelvic floor, and the hernia can involve the uterus dropping through the vagina, or the bladder dropping through the vagina, or the rectum dropping through the vagina, or two or all three of those things happening at once. For those that have a problem that needs treatment, the option is either to use a pessary, which is a device that sits in the vagina to support the tissue, or surgery. The surgery can be done vaginally or it can be done abdominally, and it can be done with a traditional suture-based repair, or it can be done with mesh implants or sometimes biologic implants. This is an example of one of the meshes that can be used for stress incontinence surgery. And typically it gets placed around the urethra in such a way that if you were to look at my hand as the bladder and my finger coming out as the urethra, the sling sits about like this. There are larger pieces of mesh that are used to correct the prolapse, and they're placed between the vagina and rectum or between the vagina and bladder and anchored to pelvic structures to help hold the vagina up. It's pretty well accepted that the sling and the abdominally placed mesh have relatively lower rates of risks and complications, and so the FDA warning really wasn't applying or did not apply to those two procedures. It more specifically applied to vaginally placed mesh around the vagina, and it has to do with a couple of reasons. It tends to have higher rates of pelvic pain, pain with intercourse, what's called mesh erosion, and then some other problems as well. Part of the reason for that is you have to place it through a vaginal incision, and that vaginal incision does not always heal over the mesh. The vaginal tissue is only a few millimeters thick, and it may not heal over the mesh. When you place it abdominally, you don't run into that problem. We offer all different types of repairs. I'd say our top priority is to try to get the surgery done without an implant if it's possible. And so if we can do a traditional suture-based repair and do it vaginally, that's the quickest surgery, it's the fastest recovery, and it has the least overall risk. And so we'll typically recommend that first to patients. Then when we start recommending implants is when one of the following situations occurs, is when it's an advanced prolapse where it's really likely to fail without using an implant, or if it's a recurrent prolapse and it has already failed. Probably one of the best things about repairing these problems is that the patients are surprisingly happy when they get this fixed. I mean, it's not cancer, it's not a life-threatening condition, it's a pure quality of life condition, but the amount of symptom relief they get from it is obviously quite remarkable.